Hi, everybody. So, I'm sorry because I'm not a radiologist, so I hope you'll forgive my poor radiologic skills. And so the main part of the work was done by Marine Bravetti, who is a radiologist in Philippe Cluzel's lab in Paris, in Pitié-Salpêtrière. And so I will tell you a little bit about more. So why we started to... Do you see? Okay, sorry for that. So when I started interesting myself, or when ECD came to me more than 15 years ago, so I was interested in cardiovascular involvement of this disease, and I saw it was clearly something that was overlooked. And in this first work, published in 2004, we saw that 11 patients out of 35 died from cardiovascular complications, which were mainly heart failure. We had tamponade, myocardial infarction, etc. And so that was the basis of some of the work we did afterwards. And in 2011, this retrospective cohort of 53 patients, and you can see that in this multivariate survival Cox model, there was only CNS involvement that was statistically significant of worse prognosis, but the cardiac involvement, cardiovascular involvement, was not associated with the worst prognosis in this later cohort. About less than 10 years ago, we started doing systematic cardiac imaging to patients, and it was mainly MRI when we could, and you can see that about 2/3 of patients had abnormal heart imaging, and that we started seeing like about 1/3 had this pseudo-tumoral infiltration of the right atrium, and I will talk about it later. And most of the patients had other feature, and this is what I'm going to talk later today. This is one of the first patients that I saw like dying of ECD, and this is at the time of the death. So this patient underwent surgery for valvular replacement, and it was the surgery was a failure, and she had a tamponade, and after she went into ICU for 6 months. And at the time of the death, you can see that the pseudo-atrial infiltration, this is the mass in 3 parts, and it was like more than 10 centimeters wide. So this was one of the questions that we started asking with this kind of localization. And this is another historical piece of autopsy finding of a patient in Lyon, and you can see that all the layers of the heart, the epicardium, pericardium, the valves, and myocardium can be widely infiltrated by this disease. So recently, in this analysis back in August 2018, we had seen like 217 patients with ECD, and you can see here the V600E patients and the wild type, and you can see, like, if you correlate, you can see that there is a very strong link between cardiac involvement and BRAF, particularly when you have the right auricular mass, which in our experience is almost always associated with BRAF mutation, xanthelasma, diabetes insipidus, and CNS involvement. But the link between BRAF and the cardiac involvement is very, very strong in this cohort analysis. And if we do again, like what we did in 2011, this Cox proportional model, you can see that the CNS involvement is associated with a worse prognosis, the lung involvement also, the RPF involvement, but not cardiac involvement. So it doesn't seem to be associated with a worse prognosis. as opposed to LCH, and particularly to LCH pediatric cohort. As of today, among the patients we have seen in Pitié-Salpêtrière, if you see the difference between V600E and wild-type patient, there is no statistical difference between the two cohort of patients, and so BRAF patient doesn't seem today to have a worse prognosis. So the flow chart of the patients seen at Pitié-Salpêtrière and who had a heart imaging. So we had 220 patients seen over about 12 years period. And so 191 cardiac examination and 39 without. So I don't really know why they didn't get the MRI of the heart, but I think this should really be systematic. So we had 184 MRIs, 7 with CT, because they had 3 pacemakers, and sometimes they were claustrophobic, and so they couldn't take go into the MRI. And so we had 92 MRI which were normal, 92 which were pathologic, and among the CT we had 5 pathologic exams and 2 normal. So it means that about half of the patients have an abnormal imaging of the heart. So this is the main finding we find is the right atrioventricular groove. So 77%, this is out of the 91 patients. So it means that about 40% of the patients have this right atrioventricular groove infiltration. You have the right atrial wall also infiltration, which I will show you example. And much less frequent, you have left groove and aortic root. You have about more than half of the patients who have pericardial involvement, which can be infiltrated with effusion or thickening, and much more rare we have myocardial and valvular. Almost all of the lesions are enhanced, and the left ventricular function is mostly preserved, and the TAPC, which is the tricuspid annular plane systemic exploration, which explores the right ventricular function, is mostly preserved. So it's only lowered in about 10% of the patient. And you have one localization in 1/3 of the patient, and 2/3 have at least 2 types of involvement. So this is an example of, oh, it moves, so that's very nice. So this is an example of the right atrioventricular groove infiltration, and this is something that has become over the years one of the iconic feature of ECD. So that's again 77% of the patients seen in this cohort. And another kind of localization is the right atrial wall infiltration, which is about 70% of the patient. You can see very nicely on this cine with the arrows. And on the next, you can see, so I'm not really familiar with this, but that's the TAPC, which is preserved in ECD, and which is only lowered in about 10% of the patients. So, and here you have the right coronary artery. So this is an example, very severe, where you can see that the right atrium here is almost narrow. It's very narrow, and there is almost no. Sorry for that. Yeah, there is almost no room for it, and you can see it in another incidents here. here you have another example of a much more rare localization of the involvement, which is on the left atrium here. So this is only 5 to 10% of patients. This is the left coronary artery. And finally, those are the results of enhanced and with effusion of the pericardial. And you can see here the enhancement with the gadolinium. So we try to correlate the normality or abnormality of the heart images with the BRAF stages. So you can see here, those are the patients with positive cardiac or CT. So there are mostly V600E patients with about less than 10% that are BRAF wild type. And on the contrary, those are the normal CMR or cardiac, which are mainly wild type, but are also a little bit V600E. And there is quite a strong association between BRAF stages and the fact of having an abnormality of your heart images. BRAF mutated patients have a heart imaging abnormality in about 2/3 of the patients, and a normal imaging in about 1/3. And you can see here, those are the V600E, the wild type, and with the differences between the positive and the normal images. If we try to correlate now the status death or alive versus the heart imaging, we find no statistical differences or statistical link between the fact of being alive and finding this kind of abnormality. Another quite interesting thing is we could, among certain patients, evaluate the response to treatment with a baseline MRI and the MRI at 1 year, and with quite impressive regression of the size of various tumors, which could be in the posterior atrial wall or the right atrial groove. And you can see the disappearance of the enhancement of many of the lesions. So something I've been speaking about last year at ASH, or it was actually a poster, but more recently at the Histiocyte Society, was something we developed among the patients we see in Paris, is to do NGS on the medullogram of patients with ECD. And in this cluster analysis, we saw there was a very strong link between BRAF status and TET2 mutations among our patients. And what is interesting is that in this publication from the New England from 2 years ago, I think by Ben Ebert's group, was the association between the CHIP and coronary heart disease and early onset myocardial infarction among patients from his cohort. And also in this mouse model, he was able to correlate TET2, loss of TET2 and atherosclerosis in a murine model, and also among various locations of the aortic root. So one of the questions which still remains is the link between TET2 and BRAF among the patients of our cohort. So clearly the right part remains involved and is clearly an iconic presentation of ECD, with about more than 1/3 of patients having either the right atrioventricular groove or the right atrial wall localization. The heart involvement is linked to BRAF status, and this is very statistical, but not to mortality. And I think there is clearly an importance for cardiac MR, which should be systematically done, because when we look at the files of our patients, about half of the abnormality could not be found on transthoracic echocardiography. So there is clearly a need for maintaining this examination in the assessment of patients. And so those are partial results because this is just imaging, and we have to correlate with looking for the atrioventricular conduction defect, so looking at all the electrocardiograms of the patients. Also correlate perhaps with NT-proBNP and troponin, which is something we should definitely do. Look for correlations between BRAF and possibly TET2 also. I didn't do it in the present analysis. And also with another, I just correlate with heart imaging and BRAF status, but I should really do that for the right atrial, the right atrioventricular groove and the right atrial wall, and I think it will be even more significant, the link between BRAF, TET2 and those localization. And I think there is also a need for an electrophysiological studies, which should probably be systematic, because if you look at where the mass are located, you should definitely explore those areas of the heart, and so also perhaps systematically have a cardiologist on board and not do that as we've been doing it up to now. And so with that, I thank everybody from members from internal medicine department and also obviously the vascular radiology department, who did a great job among the years. Thank you very much.
Among the patients with a cardiac involvement, can you estimate how many % of those patients actually came in with a cardiac primary symptom? I assume most of these cardiac involvement were found as part of the staging because they already have a diagnosis. Do you have any idea of how many % would come in because they have pleural effusion or chest pain, primarily cardiac? Thank you.
I would say maybe between 10 and 15%, like for pericardial effusion or pre-tamponade. Some had already a pacemaker for auriculoventricular blocks. Very few had low ventricular LVEF fraction. So and so that's about it. And we had also some patients who had myocardial. I have also to correlate with the patients who had myocardial infarction, and we have also found a couple of the patients, particularly the patients who were reassessed after 1 year or 1 month after 6 months or 1 year of treatment, who had developed silent myocardial infarction. And when you see the localization of the right coronary artery, it's not totally surprising, especially if you are a patient who is about like 50 or 60, and if you have other risk factor for coronary heart disease. So also probably to be quite easy asking for coronarography also as well, and add statin and aspirin.
Of those patients that you're staging and you didn't suspect they had any cardiac problems, but you do find cardiac abnormalities.
Yes.
How many of those you end up having some sort of actual intervention that changed what you would have done? Meaning antiarrhythmics or stent, pacemaker, defibrillators, things like that?
I would say 10-20%. But I mean, I would have to do that in a systematic way. This is the analysis of has been done just by the radiologist, and so I got the analysis about a couple of weeks ago, and so I started looking at everything and trying to correlate, but I didn't precisely correlate with the history of the patients, like the drugs they were taking and why they had a pacemaker. And so I'm trying to match both things right now, which is sometimes a little bit
Because the
difficult.
important message for us that see those patients, that we stage them, okay, but
Yeah.
maybe 1 out of 5 you end up doing something that you wouldn't have otherwise have done.
Exactly, yeah. And really no parallelism between, and that's what the cardiologists say, between echocardiography and MRI, because so you see the pseudoatrial tumor when it's big, mainly when you do a transesophageal echocardiography, but you're not doing to do that for patients. So